Hello, welcome to the EKG Guy and welcome to the EKG of the Week. I hope you're having a great week and I'm glad you could join us. So this week's case is a 67-year-old male with locally advanced non-small cell lung cancer of squamous cell histology. His presenting EKG is shown here. Now before we get started, let's review the approach we've been using to interpret EKGs. So notice that we have the patient's clinical presentation and then the EKG below. On the right side of the screen, you can find a list of the different criteria that we'll go through before making our final interpretation. First, there's the regularity of the rhythm. That is, are we dealing with a regular or irregular rhythm? And if it's irregular, is it regularly irregular or irregularly irregular? Next, we have the heart rate, in which we simply want to determine the rate of the rhythm. Then we'll look at the rhythm origin. That is, where is the rhythm actually starting from within the heart? Then we have to determine the ventricular or QRS axis, which could help us with our differential diagnosis. Then there's the atrioventricular, and intraventricular conduction, looking at if the conduction is normal or abnormal in any area of the heart. Then we have the waveforms, which would include all the waves, the segments, and intervals, and lastly, anything else, meaning is there anything else we have missed or still need to mention, such as abnormal R wave progression or the transitional zone in the precordial leads. After that, we'll use all the information that we've gathered to make a final interpretation of the EKG. Now, I want you to pause the video and take a few minutes to go through it yourself. When you're ready, start the video and we'll walk through it together. Okay, so our 67-year-old male with locally advanced non-small cell lung cancer of squamous cell histology has this EKG. So let's go through it. So first, what is the regularity of this rhythm? Well, on first impression of this EKG, you probably notice that the rhythm appears irregular. In fact, this is an irregular rhythm, but this is a regularly irregular rhythm. That is because if you were to measure the R to R interval between the first few complexes, you would see that the distance generally holds true throughout this ECG. However, there's one beat that comes a little later than expected, making this irregular. But the beats that follow that delayed beat occurred where it is expected to, such that if you were to measure that, it would come out to 2 times the regular R to R interval. That beat occurs where it would be expected, and we'll look at that shortly. Okay, so this is similar to what we would see in escape beats. Okay, so overall we would call this a regularly irregular rhythm. Okay, so we can write that up here. Okay, so regularly irregular. Okay, and what I was saying here is that the R to R interval from this to this, okay, from one R wave to the next, you could see that it's the same through here. Okay, so from this R to R interval is the same as the following one. Okay, and then the one that comes after it is also the same. And then you'll notice that this distance from this R wave to this R wave is actually a little longer. Okay, so it's not the same as those that precede it. However, that R wave that comes after it, okay, if you were to measure this out from this R wave until this one, okay, or that S wave, you would see that's 2 R to R intervals. Okay, so it's almost like compensated for. Okay, so it's where we would expect the beat to fall. Okay. Now, if you were to look at just the P waves here, you could call it a regular rhythm because all the P waves occur at regular P to P intervals. Okay, so when we look at the R waves or the QRS complexes, you could say that's a regularly irregular rhythm. Okay, so we'll put that here, the QRS complexes. However, if you look at the P waves, and one of the best ones to look at it is in lead 2. So if you look right here, here's lead 2, the rhythm strip. Notice that we have all these P waves, okay, that are occurring. These are all small P waves that are occurring here. Okay, there's one that's actually occurring within the QRS complex. Okay, that's starting to give away what the rhythm is, but all of these intervals from one P wave to the next are all the same throughout. Okay, and these are all P waves. So those P waves that we see here are in fact a regular rhythm. Okay, so when we look at the ventricular or the QRS complexes, that's more of a regularly irregular rhythm, but with the P waves, this is more of a regular rhythm. Okay, and that may give you a clue of what the underlying rhythm will eventually be. So what did you get for the heart rate? Well, we have an irregular rhythm in terms of the QRS complexes. So we want to count the number of complexes going across, okay, that 10-second standard EKG that we have here, and then multiply that by 6 to get an estimate of the rate. Okay, so if we do that here, remember this whole width from the beginning to the end of the EKG represents 10 seconds. So 10 seconds times 6 is 60 seconds, which is 1 minute. Okay, so if you count the complexes going across, multiply by 6, we'll get an estimate of the ventricular rate. Okay, so let's do that here. I'll erase this so you can see clearly. Okay, so we have 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11. Okay, so our ventricular rate, okay, we'll call it our QRS rate, is equal to 11 times 6, or about 66 beats per minute. Okay, the actual rate here was 69. Okay, so very close. I'll put it here so you can see it. So that was the actual rate on the machine. Okay, now in regards to the atrial rate, okay, because they're occurring at different intervals compared to our QRS complexes, we can count the number of complexes going across, which I actually did for you, so we don't have to go through them all. But it comes out to 46 P waves. Okay, and then we would do 46 times 6, and that would give us an estimate of the atrial rate, which came out to 276 beats per minute. Okay, so what I mean is that you would count all these P waves going across. Okay, so all of these that are circled here, some that are falling actually within our QRS complexes, and if you counted from the beginning, okay, all the way to the end, you would have 46 P waves. Okay, so we would do for our atrial rate, it would be 46 times 6, okay, and that gives you 276. All right, so that's an estimate of the atrial rate, 276 beats per minute, okay? So we have two different rates we're looking at, a ventricular rate, about 69 beats per minute, and then this atrial rate of about 276 beats per minute. Now let's look at the rhythm origin. Well, we have narrow QRS complexes, so it must be supraventricular in origin, that is originating from above the ventricles. Now we need to ask ourselves if we can make out any clear P waves with similar morphology, okay? Because we have to determine, are we dealing with sinus rhythm? In addition, we need to see if there is one P wave for every QRS complex. And you probably noticed that we don't have one P wave for each QRS complex, okay? So we're actually not dealing with a sinus rhythm, okay? But we can see clear P waves that we've already circled here. Therefore, we're likely dealing with a rhythm originating from the atria, okay? So remember, we can see all these P waves, but notice not all the P waves have a corresponding QRS complexes, okay? There are many more P waves compared to the QRS complexes, okay? So the rhythm is likely originating from somewhere within the atria, okay? So there's an atrial origin, okay? So now let's look at the ventricular or QRS axis, okay? So we can still do that here, and you should have gotten a leftward axis, okay? The actual value here was negative 48 degrees, okay? So the ventricular axis will be negative 48 degrees, which is a leftward axis shift or left axis deviation. And let's see why that's the case. So first of all, remember this is 0 degrees, where the positive end of lead 1 sits. This is positive 90 degrees down here, and that's the positive end of AVF. Okay, this is plus or minus 180 degrees, and then this would be negative 90 degrees. So we're going to look first, we'll take a look at leads 1 in AVF. Okay, so lead 1 is here. Notice that we have these positive upright complexes heading in this direction towards the positive end of lead 1. Then if we look at AVF, okay, we are going towards the negative direction. So this is the positive end of AVF, so we're going away from it. So our axis falls somewhere within this region, okay? Now we have to determine, remember that normal axis lies between negative 30 degrees and about positive 105 degrees, okay? So this is all normal axis here, okay? This would be a right axis shift, okay? This is normal. This is left axis deviation, okay? And this is what we consider extreme axis deviation or no man's land, okay? Now we have to determine where within that this area we actually are, okay? So remember, we're somewhere within this area, but we have to see if we're in this normal region here or are we in that leftward axis deviation, okay? So let's look at this. What we have to do is look at another lead, and that lead is lead 2. So lead 2 actually comes about right here. That's the positive end, and it's at positive 60 degrees. And the perpendicular line to lead 2, okay, is actually runs right here. Meaning that if lead 2 is positive, okay, on this end, it will fall in that normal range. If lead 2 is negative, then we'll be in this leftward axis shift, that pathological region. Okay, so let's take a look at lead 2. Lead 2 is this one here, and notice that these are mostly negative complexes, putting us on this side. Okay, that means our axis lies somewhere within here. And if you recall, our axis was actually negative 48 degrees. Okay. So where does negative 48 degrees come at? Well, look here. This is negative 30, This was about negative 48 degrees, okay? So hopefully that makes sense there. So left axis deviation and the actual axis here was negative 48 degrees. That's our ventricular access. Okay, so let's now look at atrial conduction. Well, typically we'll look at leads 2 and V1 for P wave or atrial abnormalities as they appear to be most evident in those leads. There's no significant prolongation or increase in amplitude in the P waves, but you may have noticed that some of the P waves are actually buried within the T wave, okay, which makes the T wave appear as if it has a greater amplitude. Okay, so let's take a look at that. Okay, so if we erase some of this here, okay, lead 2 is probably the best lead here we have to see these P waves that we're talking about. And notice that here's a P wave, here's a P wave, okay? There's actually a P wave that's buried within this QRS complex, and then here's another P wave that's buried within that T wave, okay? Notice that the P waves that come after are smaller in amplitude, okay? P wave buried somewhere here, and then notice this T wave also has a P wave within it. That's why the amplitude of these T waves or P waves are higher, is because you have a P wave that's buried within it. Okay, notice that the T wave is greater in amplitude, and that's because that P wave is buried within it. Okay, so hopefully that makes sense. So no abnormal atrial conduction that we'll mention at this point here. Now, how about atrioventricular or AV conduction? Well, in this case, we're looking for any conduction delays as the impulse travels between the atria and ventricles, and because the majority of the PR interval represents AV nodal conduction, that's where we tend to look. Now, the normal PR interval in adults is between 120 and 200 milliseconds, or 3 to 5 small boxes. However, in this case, because every P wave is not associated with a corresponding QRS complex, we can't really comment so much on the PR interval. I mean, you can look at these P waves that have an associated QRS complex, okay, and check at that point, but because each P wave does not have a corresponding QRS complex, I'm really not going to comment too much on that now, okay, at this point. All right, so we're not going to say much with the AV nodal conduction or the PR interval because it's variable in this sort of rhythm that we'll discuss shortly. Now, how about the intraventricular conduction or IV conduction? Okay, so here we're looking at the duration of the QRS complexes. Normal QRS duration, remember, is between 70 and 110 milliseconds, or about 2 to 3 small boxes. The main thing we're checking for is intraventricular conduction, is whether the QRS interval is prolonged or not, okay? So we can see narrow QRS complexes here that appear within normal limits, and in fact the QRS duration was 92 milliseconds, so that helps to confirm that IV conduction is actually normal here, okay? So we have normal intraventricular conduction, the QRS interval was 92 milliseconds, okay, within that normal range. Now, how about the waveforms? We already discussed the P waves. There are no pathological Q waves or QS complexes in the EKG. While there appear to be deep Q waves in lead AVF, they're not contiguous in the other inferior leads. Lead 3 has evidence of small R waves and no Q waves there. We see normal T waves that are asymmetric with a slow upstroke and steeper downslope. Remember, the T waves have a greater amplitude here because of the buried P wave within them, okay? So it makes them appear quite tall at times to their corresponding QRS complexes. The PR segment and interval we won't comment much on at this point because of the multiple P waves and not having a corresponding QRS complex. But if we look at the P waves preceding a QRS complex, there's nothing significant to comment on. The ST segment does not appear to be significantly depressed or elevated anywhere. The ST segment elevation in some of the precordial leads that you may see is not significant, okay, and can be reassured with that concave morphology in the patient's presenting symptoms, okay? No chest pain or shortness of breath or anything that we kind of think of for more cardiac related. The QRS interval we said was within normal limits. The QRS amplitude does not seem to be abnormally increased or decreased throughout the EKG. And lastly, with the waveforms, the QTC interval is slightly prolonged at 477 milliseconds. Now remember, normal QTC interval in males is less than 440 milliseconds, okay, and in females it's less than 460 milliseconds. Remember, in this case it's difficult to say if this is true prolongation with that P on T wave occurring, okay? Maybe that P wave is coming at the end of the T wave, kind of making it look prolonged, okay? It would just be something to be aware of and note in the in the clinical setting. So overall, there's no major waveform abnormalities, maybe some non-specific ST T-wave abnormalities that we'll write for this point. Okay, so we'll write here non-specific ST and T-wave abnormalities. Okay, so that's pretty much the main thing there. All right, so is there anything else we're missing here? Well, how about the R wave progression in the precordial leads? Normally the R wave amplitude should progressively increase from leads V1 to V5, and in this case it seems pretty normal with a steady progression from lead V1 to V5. Okay, so notice here's our R wave. Notice the amplitude is increasing as we go through each precordial lead from V1, V2, V3, V4, and V5. Okay, so we have normal R wave progression, so we can write it here. Okay, and then how about the transitional zone in the precordial leads? Well, here it appears to be between V3 and V4. Remember that the transitional zone is simply the precordial lead where the QRS transitions from being mostly negative to mostly positive, with the actual transition area to be where the QRS is isoelectric. Normally the transition occurs between leads V3 and V4. If it occurs earlier than V3, remember we call that a counterclockwise rotation or early transition. If it occurs after lead V4, then it's called a clockwise rotation or late transition. Okay, and because the transition in this case occurs between V3 and V4, we call this a normal transition. Okay, so again, I just erase this so you can see it. So remember, we're seeing where does the QRS complex in the precordial leads, remember the precordial leads are on this side, V1, okay, through V6. Where does it go from being mostly negative to mostly positive? So V1, notice it's mostly negative, same thing in V2 and in V3, and then once you get to V4, it becomes mostly positive, almost isoelectric. Okay, so we have a normal transition occurring somewhere between V3 and V4. Okay, and because of that, we call that a normal transitional zone. Okay, so we'll say normal transition in the precordial leads. Okay, now one thing to keep in mind is that the R wave progression and the transitional zone in the precordial leads is highly dependent on lead placement, which is still an imperfect science. Another thing to note here is that there's no isoelectric baseline. Okay, this is especially true if you look at the rhythm strip of lead 2. Remember, that's where we're looking at all those P waves. Okay, so notice here's lead 2, and notice how you have this undulating pattern. Okay, with no clear baseline. Okay, you just have these P waves that are going up and down throughout, even occurring within our QRS complex. Okay, so if you were to draw this out, you'd see a P wave that's actually coming through our QRS complex. Okay, so this is the main thing here I wanted to point out is that there is no isoelectric baseline. Okay, that's an important point for this underlying rhythm that you're probably starting to figure out. Okay, so no isoelectric baseline. Anyway, so what is our final interpretation? Well, we have a rhythm that has these regular P to P intervals, okay, and then we have the regularly irregular R to R intervals. In other words, the regularity here is what we can call is variable. Okay, so if you want to sum this up, we can call this a variable. Okay, in this case. The ventricular rate is 69 beats per minute, so we saw that. The atrial rate, we said, is about 276 beats per minute. We're likely dealing with a rhythm with atrial origin because of the multiple P waves that we saw, which actually have what we call a sawtooth appearance with an undulating appearance, okay, and a regular P to P interval. In addition, it's less likely to be a junctional rhythm with this ventricular rate. Remember, junctional rhythms have a rate often between 40 and 60 beats per minute. Our ventricular rate here is above that, okay, 69 beats per minute, almost 70. So that's a little fast for a junctional rhythm, okay. Now, the ventricular access, we said, is leftward shifted, right, negative 48 degrees, which suggests something that you may have noticed, left anterior fascicular block, okay? This is also supported by QR complexes in lead AVL and a monophasic R waves in lead 1, okay? So if you look at lead 1, I'll just erase this so you can see it, okay? So lead 1, you can see these monophasic R waves. These are both monophasic, and then if you look at AVL, you can see a small Q wave there, okay, also there, and then a big R wave. So we call these QR complexes, okay. And another thing that supports left anterior fascicular block are RS complexes in the inferior leads and a normal QRS interval. Remember, our QRS interval we said was 92 milliseconds, okay? And then we mentioned these RS complexes in the inferior leads. Okay, here's 2 and 3. Here's a R wave and an S wave. Same thing here, okay? And maybe there's one here in lead AVF, but again, those are not significant Q waves because we don't have them in contiguous leads, okay? So we do have RS complexes in at least 2 of the inferior leads, okay? So all those things support left anterior fascicular block. Now we mentioned that there's no isoelectric baseline, okay? And we said that intraventricular conduction was normal here. We also saw a normal R wave progression in transitional zone in the precordial leads. So taking this all together, what we have here is atrial flutter with variable AV block, left anterior fascicular block, and nonspecific ST wave abnormalities. And when we compare it to a previous EKG, there were no significant changes. You always want to make sure you're looking back at an old EKG, if available, to look for any significant changes from the most recent EKG that you have at hand. Okay, so we can write our interpretation here. Okay, so you erase this. Okay, and what we have as our final interpretation is atrial flutter with a variable block. Okay, and why do we call it a variable block? Well, if you look here, okay, you can see these undulating P waves, which we'll talk about a little bit in atrial flutter in just a second. These are called F or flutter waves. Okay, and notice that you have a flutter wave here. Here's 1, here's 2, here's 3. Okay, and there's actually one buried within this QRS complex, so there's 4, and then a QRS complex. So we would call that a 4-to-1 block, or that's what we call that. Okay, and then here's another one, 1, 2, 3, 4. Okay, 4-to-1. But then you'll see here as we get a little further down where it gets variable, and that's where we have this 1, 2, 3, 4. Okay, and there's actually this initial one here. So this is actually a 5-to-1, okay, and maybe there's 1, 2, 3 there, okay. So notice there's that irregular response, okay, and that's why we call this a variable block, okay. So you don't always see this. This is quite atypical, but that's just something to be aware of, okay. So normally throughout we've been seeing these 4-to-1 where we have 1, 2, 3, 4 and 1 QRS complex, okay, and it's variable throughout this region, okay. It's hard to make out if it's 5-to-1 or 3-to-1 or what it is, but it's not the regular that we see throughout, okay. We also mentioned that we have left anterior fascicular block, okay. So why do we have that? Well, remember we have our axis that's shifted beyond -45 degrees. We have normal QRS interval. We have that monophasic R wave in lead 1, those QR complexes with that big R wave in AVL, and then we have the small r and big S complex, okay, so the RS complex in those inferior leads that supports that. And don't forget that we mentioned we have this non-specific, okay, ST wave abnormalities, okay, and that's what you can see towards the end, okay, and that's what we call this. That's not really true infarction or anything going on, but you can see that it's not normal. You see some dipping there, okay, and remember, no baseline, okay, so that's what we tend to see, that undulating baseline in atrial flutter. And remember, when we compared it to a previous EKG, there were no changes. So compared to the previous ECG, no significant changes to be aware of, okay. Now just a few words on atrial flutter, okay? So atrial flutter is a rapid, regular circulating pulse, okay, that's most often occurring in the right atrium, but can sometimes involve the left atrium, okay? So what you have going on, if we draw this here, we have our right atrium, our left atrium, right ventricle and left ventricle. You have this impulse that's originating from somewhere. Imagine our sinus nodes here, okay? You have it originating from somewhere in the atrium, and it's going around in a circle, okay? So this circulating pulse that's going around the right atrium can sometimes involve the left atrium as well, but most often is in the right atrium. And the circuit length is proportional to the right atrium size, okay? That should make sense, okay? The bigger the right atrium is, the bigger the circuit will be, okay? Now, there's no isoelectric baseline, as we saw above here. It can be classified based on the anatomical location and direction of reentry circuit as either the typical form, which is type 1 and more common, or it can be the atypical form, which is type 2, and that's less common. Now, in our course, we go into detail talking about these different types and how to differentiate them, so you can tune into that if you're interested. Okay, we won't mention too much with regards to the different types here. Now, normally atrial flutter is regular, but it can be variable, as we saw here. Okay, the atrial rate is typically between 250 and 350 beats per minute. Okay, as we saw in this case here, 276, and the ventricular rate is between 125 and 175 beats per minute. Okay, so we saw a slower rate here of around 69 beats per minute. Okay, so not the typical form. It has that sawtooth appearance with undulating and regular F or flutter waves. Okay, that are identical throughout, and we saw that. Okay, so these waves here are what we call F waves or flutter waves. Okay, and these F waves have a greater duration and sometimes amplitude than the normal P waves. And it's often best to look at the inferior leads or V1 to visualize them. Sometimes you can even turn the EKG upside down to visualize them as well. Now the PR interval, we saw it tends to vary. Okay, we didn't really comment too much on this point here because it doesn't really affect our overall interpretation. The QRS interval is normal unless there's a pre-existing intraventricular conduction delay, accessory pathway, or rate-related aberrant conduction. And lastly, there doesn't tend to be any grouping or drop beats in atrial flutter. So that's just a little extra on atrial flutter that you may find helpful. Now, in conclusion, our 67-year-old male with locally advanced non-small cell lung cancer of squamous cell histology has an EKG showing atrial flutter with variable AV block, left anterior fascicular block, and non-specific ST-T wave abnormalities. Well, that's the end of this week's EKG of the week. I hope you learned something. Please don't forget to like this video and leave a comment below if you like what we're doing. In fact, many of you have asked how you can help us out. Really, the best way would be to simply subscribe and share this resource with your friends. You get free access to more than 300 videos. There's also a community of over 150,000 of us like-minded individuals on Facebook, so stop over and join the EKG Guy's Facebook community. If you need a crash course on EKGs, we launched our new EKG course. Check the link below if you're interested. The original cost is around $150, and I believe I made it less than $20 for a limited time. I may be biased, but after reading nearly every EKG textbook on the market, I think this is by far the best EKG series to take you from the beginner level to a physician level. I've even included our pediatric lectures. Anyways, check it out for yourself. I think you'll really enjoy it, and a number of medical schools and hospitals are beginning to use it. If you are a part of an institution, please contact us because we're giving a limited number of schools and hospitals free access to provide feedback and improve our course. And in that case, you can get the course for free. So leave a comment below and get in touch with us. And of course, check out our brand new website, ekg.md, the premier EKG resource for medical professionals, where you can find more lessons and practice. That is www.ekg.md. Last but certainly not least, your feedback is incredibly helpful, and your kind words are always an encouragement on those long days. So let us know how we're doing. Thank you again for your support. It is truly appreciated. We're the largest, fastest growing EKG resource in the world.